Let's get straight into the clinical material. We're skipping the pleasantries today to focus entirely on the exact mechanisms, intricate diagnostic traps, and discrete management steps you absolutely need for a top percentile board score. As clinicians, identifying subtle ocular pathologies and knowing instantly how to intervene, it's non-negotiable. This explainer is going to walk you through a highly integrative, mixed block simulation. Module 1, Vascular Occlusion and Hemodynamic Infarction. Let's get into it. We're kicking things off with acute arterial ischemia. Specifically, we're looking at the catastrophic hemodynamic failure of central retinal artery occlusion, or CRAO. Now, this presents as sudden, profound, and completely painless monocular vision loss. Just look at this fundoscopic signature. The sudden lack of blood supply literally turns the ischemic retina pale and completely opaque. This creates a really sharp contrast against that intact choroidal blood supply you can still see at the macula, giving us the pathognomonic cherry red fovea. And hey, in a live clinical scenario, you really want to look closely for boxcar segmentation of blood within those retinal arterioles. That's your marker for absolute stasis. Now you have to contrast this immediately with central retinal vein occlusion, or CRVO. In this case, driven by an underlying coagulopathy or maybe severe hypertension, the venous outflow is completely blocked. And the resulting backup, it causes massive capillary rupture. If you look at the fundoscopy, it reveals severe optic disc swelling, dilated and tortuous veins, cottonwool spots, and these extensive, diffuse retinal hemorrhages. It's the classic, dramatic blood and thunder appearance. All right, the absolutely crucial point here is mastering this clinical variance box. Both of these conditions are going to present with sudden, painless monocular blindness. But the hemodynamic crossovers mandate entirely different emergent interventions. You get it wrong, the patient loses their eye. CRAO gives you that pale retina and mandates immediate ocular massage and high-flow oxygen to physically dislodge the embolus. CRVO, on the other hand, yields a hyperemic, hemorrhagic retina and relies on laser photocoagulation to manage those severe neovascular complications down the line. Let's apply this to an integrated assessment. We've got an 82-year-old male presenting with sudden, completely painless loss of vision in his right eye. Fundoscopy reveals a pale retina with a distinct red spot at the macula. What is the most critical, immediate management step? As a top-tier clinician, you must bypass isolated stroke protocols here for an aggressive, targeted ophthalmic intervention based purely on what you see on exam. Evaluate these 5 distinct management pathways carefully. A. Administer intravenous TPA. B. Perform emergent laser photocoagulation. C. Execute immediate ocular massage and high-flow oxygen. D. Obtain a temporal artery biopsy. Or E. Administer topical timolol and pilocarpine. Keep in mind the strict clinical markers for retinal ischemia we just went over. Which intervention directly addresses the specific hemodynamic failure happening right now in this patient's eye? Notice how this option matrix specifically isolates diagnostic traps. Let's break it down. Choice A, IVTPA, is the standard for ischemic stroke, sure, but it is an incorrect trap for localized retinal arterial occlusion within the critical window. Choice B, laser photocoagulation, is incorrect simply because it treats CRVO, not acute arterial ischemia. Choice C is absolutely correct. The pale fundus dictates immediate ocular massage and high-flow oxygen to dislodge that embolus. Choice D is incorrect. Temporal arteritis does cause vision loss, but that cherry red spot explicitly points away from it. And finally, choice E is incorrect. Timolol and pilocarpine are used to rapidly decrease intraocular pressure in acute closed-angle glaucoma, which, remember, presents as a hard, acutely painful eye. Not a painless one like we have here. Moving on to Module 2, Optic Neuritis and Demyelinating Kinetics. We are moving aggressively into inflammatory demyelination now. This sequence diagrams the exact kinetic failure of the pupillary reflex in optic neuritis. It starts with localized inflammation of the optic nerve, frequently presenting as an initial symptom in young women with multiple sclerosis. Because of this, the damaged nerve fails to transmit sensory afferent signals. So during the swinging flashlight test, when you move the light from the normal eye to the affected eye, it triggers a paradoxical response. Both pupils visibly dilate instead of constricting. This is the relative afferent pupillary defects, or the Marcus-Gunn pupil. It's a massive, high-yield clinical marker. You absolutely have to know this. Now, study this clinical variance box closely. The absolute clinical divergence between these 2 unilateral vision loss presentations rests entirely on 3 things: pain, duration, and color perception. Optic neuritis is painful, it lasts days to weeks, and severely degrades color perception, which we call dyschromatopsia. Conversely, amaurosis fugax is completely painless. It lasts only minutes, literally like a curtain falling over the eye, and color perception remains completely intact. It's usually driven by a displaced carotid embolus or temporal arteritis.
Okay, let's apply those discrete markers to this exceptionally difficult third-order assessment. We have a 28-year-old female complaining of rapid, painful impairment of vision in her left eye, particularly severe with eye movement. She specifically notes that colors appear faded or washed out. Examination reveals that paradoxical pupillary dilation we just discussed when light is swung to the left eye. What is the most appropriate next step in diagnosis?
A. Perform a slit lamp examination. B. Measure intraocular pressure with ocular tonometry. C. Obtain an MRI of the brain and orbits. D. Schedule a carotid ultrasound. Or E. Initiate immediate high-dose corticosteroids without imaging. You must correctly identify the underlying systemic pathology driven by this presentation and select the definitive diagnostic modality. Evaluating these options, identifying the need for an MRI to map periventricular demyelinating plaques entirely rules out our distractors. Let's look at choice A. A slit lamp exam evaluates the anterior segment, not the optic nerve, so that's out. Choice B, tonometry, looks for glaucoma, which presents with a fixed mid-dilated pupil, not an afferent defect. Choice C is the correct answer. An MRI of the brain and orbits is the undisputed gold standard for mapping the demyelinating plaques characteristic of MS. Choice D, a carotid ultrasound, that's the workup for painless amaurosis fugax, which completely avoids the painful, color-deficient presentation we have right here. And choice E, immediate empiric steroids without imaging, well, that's the treatment for temporal arteritis in the elderly, not for isolated demyelination in a 28-year-old. Finally, Module 3, anterior uveitis versus episcleritis. Transitioning to the anterior segment, we really need to contrast deep uveal inflammation against superficial, benign irritations. Look at this image. Note the intense, concentrated conjunctival injection right adjacent to the cornea. That's your ciliary flush. And check out the highly visible hypopyon, which is that distinct layering of white blood cells sitting right there in the anterior chamber. Guys, this is not your standard run-of-the-mill red eye. This is a severe, sight-threatening anterior uveitis that requires aggressive medical therapy. This final clinical variance box is critical. Both of these conditions are going to cause a red eye. However, anterior uveitis severely distorts visual acuity and pupillary shape due to posterior synesthesia, and it's intensely photophobic. Episcleritis, on the flip side, is a benign condition. It completely spares visual acuity and pupillary reactivity, presenting merely as a localized, patchy redness. Furthermore, don't forget that anterior uveitis is heavily linked to HLA-B27 systemic conditions like ankylosing spondylitis. That's a huge clue to look out for. Let's integrate the systemic history with the acute ocular findings to conquer this final challenging presentation. A 30-year-old male with a history of chronic lower back pain presents with acute, painful redness in his right eye. He reports severe photophobia and blurred vision. Examination reveals a distinctly constricted, irregular pupil and a localized layering of white blood cells in the anterior chamber. What is the most likely diagnosis? Lock in on the absolute clinical markers here: the systemic lower back pain, the constricted pupil, and that distinct anterior chamber layering. Evaluate these 5 choices. Is it A, acute angle closure glaucoma, B, infectious keratitis, C, anterior uveitis, D, episcleritis, or E, endophthalmitis? Let's break this down to arrive at the precise diagnosis. Choice A, acute angle closure glaucoma, is incorrect. While it does cause a painful red eye, the pupil is classically mid-dilated and fixed, not constricted, and the eye feels hard to palpation. Choice B, infectious keratitis, is primarily a corneal infection causing opacification, not an anterior chamber layering, and it completely lacks that systemic link. Choice C is definitively correct. Anterior uveitis perfectly matches the lower back pain, suggesting an HLA-B27 condition like ankylosing spondylitis, paired seamlessly with the painful red eye, photophobia, constricted pupil, and hypopyon. Choice D, episcleritis, is incorrect because it spares the pupil and vision entirely, making it way too benign for this presentation. And choice E, endophthalmitis, is incorrect as it almost universally follows intraocular surgery or severe trauma, which this patient just doesn't have. Mastering these specific structural adhesions, discrete management steps, and linking them seamlessly to systemic pathology is exactly what secures top-tier board scores in clinical ophthalmology. Let's keep pushing that standard.